Okay, good morning everyone. Today's lecture topic is relining, rebasing, and repair and complete denture. Okay, so coming to the learning outcomes. So at the end of the lectures, you all will be able to describe various techniques involved in the denture repair, relining, and rebasing. Also, you'll be able to identify potential problems associated with denture repair, relining, and rebasing. Rebasing. Sorry. Okay, coming to rebasing. So rebasing is a procedure replacing all the denture materials of the denture. Only the original teeth or the teeth arrangement would remain. So it consists of replacing all the denture base with a new denture material. Okay, coming to the general complaints, why do we have to do these procedures? So one reasons can be looseness, which is like the ill-fitting dentures. There is always inflammation and soreness in the tissue regions, um, and the ridge region, sorry, and there is chewing inefficiency over a period of time. So the patient is using for a long time, still he's not able to masticate, and aesthetic issues. Okay. So coming to the objectives, so the main objectives are a few, that is to reestablish the correct relation of the denture to the basal tissues, to restore stability retention, which is one of the most important factors in fabrication of a complete denture. Another one is to restore lost occlusal and maxillomandibular relationship. So to restore jaw relation in short. Okay. So indication of relining. So there are many more indications. These are the main indications which we should be focusing on, which is the alveolar ridge resorption, decrease occlusal vertical dimension. So the reduction in the VDO and immediate denture. So you'll have to again reline them after the healing of the tissue. Okay, so there are many contraindications. So these are especially in the unresolved TMJ issues, disharmony, and myofascial pain. Also, if there is abuse tissues, there's pathological issues in the mucosa, there's inflammation. The teeth setting which was done is in a mal position. There are multiple fractured tooth or really worn out artificial tooth, then we do not use it. Any unfavorable occlusal plane which produces a poor appearance. So sometimes you'll see unfavorable occlusal planes when maybe there is opposing tooth and we are doing like a single complete denture, right? So if occlusal plane is not fine, we should not be, relining the same denture, relining or rebasing the same denture. So if they are deflective occlusal contacts, so the deflective occlusal contacts means, so it's like a condition in which um, the tooth contact divert the mandible from the normal path of closure. So they are going to divert the closure of the mandible in different directions. So these are the deflective contacts. So it's present in the centric relation, which is greater than 2 mm, and in horizontal, and 3 mm in the vertical. Okay. Okay. So a vertical dimension of occlusion that must be increased more than 3 to 5 mm. So the VDO, if it has to be increased a lot, then it's not indicated, then it's contraindicated. Again, if there is a lack of interocclusal space, then also this is contraindicated. Okay. So coming to the general consideration prior to relining or rebasing, so that is satisfactory VDO. If there is a satisfactory VDO, if the centric occlusion coincides with the centric relation, then we can do it. So if there is a satisfactory aesthetics, definitely we can do it. If there's healthy tissue, the denture extension is fine, and there is a satisfactory speech, can be done. Okay, so there are various materials which is used, and then we'll come to the various techniques. So firstly is PMMA, that is obviously polymethyl methacrylate. Comes in two forms, the heat cure and the cold cure. Modification of PMMA is a butyl methacrylate acrylate. So this also can be used. Soft liners or the tissue conditioners can be used. So these are plasticized acrylic resins. So chemically activated and heat activated. Chemically is the short-term denture liners, and heat activated are the long-term denture liners. Okay, coming to vinyl resins, then silicone materials, which is chemically and heat activated. Okay, coming to the treatment procedures. First, before doing any relining, rebasing, we're supposed to do some tissue preparation. So comes to the tissue rest. So first of all, the denture should be left out of the mouth for 2 or 3 days before making the final impression. Okay, massage of the soft tissues 2 or 3 times a day to simulate the blood supply and aid in the recovery. So massaging leave out of position is done. And then now use of the tissue conditioner. Indication: extensive tissue abuse is there. A patient cannot leave the dentures out for tissue recovery. So obviously this cannot be done. So these are the indications of tissue conditioner, and the time period is, of course, it has to be renewed periodically, 3 to 7 days, because this is not a permanent treatment and it's not a permanent material, right? It's a temporary material. So what is the result? The tissues then will return into a healthy state, and then patient can be scheduled for making the impression. So coming to another management is of the tissues before doing the relining. The treatment can be done is surgical management. So excessive hypertrophic tissue should be surgically removed. The denture can be used as a surgical splint. Okay, and then the denture preparation is done. So once the denture preparation is done, we have to reduce all the sharp border. Any overextension has to be reduced. Pressure areas in the tissue has to be relieved. Undercuts to be relieved. Minor occlusal disharmonies have to be corrected. The correct posterior seal, palatal seal, has to be established before the impression. Impression surface to be trimmed about 1 mm to allow space for new impression material. Okay, so the treatment basically is divided into three types, that is the clinical, lab, and chairside. Coming to the clinical procedure, so in the clinical there is a static method which has a open mouth technique, closed mouth technique, and functional technique. Lab procedure, which is the articulator method, jig method, flask method, and then coming to the chair side. Okay. Okay, so you can see that the denture is taken out from the patient's mouth. The surface has been trimmed, the borders are trimmed a little bit. Now the bottom molding materials is put, and then the final impression material put on top. Okay, so advantage is that selective trimming helps in making the selective pressure impression. Okay, so we can provide the pressure at the right places. Inter-occlusal record is more reliable, um, and stable bases allow operator to concentrate more on the jaw relations, right? So these are the advantage of that method. Disadvantage is difficult procedure because more clinical and lab work is involved. And a closed mouth technique is another technique which is used in the clinical method. So reline or rebase cannot be done simultaneously for maxillary mandibular dentures in this technique. So firstly, centric relation is there. So dentures used as a denture, a record base and jaw relations recorded after making secondary impressions. Denture preparation is done. So posterior palatal seal is formed in modeling compound before any changes are made. So basically, okay, fine, we are not using the modeling compound. So we have to recognize that there is a distinct PPS which is shown, okay? And 1 mm space is provided inside the denture for new impression material to flow. And of course, same thing, the borders are shortened so that we get the proper border molding material. So border molding definitely is done when there's inadequate flange, okay, and then it can be corrected. Impression, ZNOE impression is taken. So 15 seconds after the denture has been placed in the mouth, the patient is asked to pull his upper lip down and open the mouth wide. Okay, so we're just doing the denture, what do you call, the impression procedure, all right? And that's how then the impression is okay. Coming to the advantages, the trimming of the denture and making room for the impression material will facilitate the making of reasonable impression during selective pressure impression techniques, okay, without any deflections or without any occlusion interferences. Separate interocclusion record will allow the operator to concentrate on recording the jaw relation. It is possible to verify the centric relation record if necessary. Interocclusal record made with quick setting plaster is a reliable one. So this also can be used, okay? So coming to the disadvantage, this technique requires more clinical and lab time, and performing the procedures is, sorry, here we are not required to use any lab procedure. So tissue conditioner is used as an impression material. So here it is, the tissue conditioner is there. Okay, so it looks like a transparent, translucent material, white color. So you can just put it in the mouth and just put it on the denture base and on the tissue surface, and tell the patient to close the mouth and do the bottom molding movements, and it will be recorded and it will stay in place. So tissue conditioner is usually soft liner with following characteristics. So we are talking basically about soft liner, so which is easy to use. It is excellent for refitting complete dentures. It's capable of retaining for many weeks. It has a good dimensional stability, good in bonding of to resin denture base. Okay, so the procedure goes as follows. So the occlusal error should be corrected so that the centric occlusion coincides with the centric relation. Okay, so this is a very important thing which has to be taken care of. So uh, tissue surface is reduced to accommodate the tissue conditioning material. Okay, tissue surface is dried and tissue conditioning material is placed. It should flow evenly as a thin layer, and it should cover the whole denture surface and the borders. Now the denture is inserted and the patient's mandible is guided to centric relation in order to stabilize the denture, and the material is allowed to set. Okay, so once the material is set, the axis is removed, trimmed. If there's a poor recording has been done because of the unsupported area, the bottom molding is done with the green stick compound. Okay, so if there is any requirement, green stick compound can also be used. So anyway, after 3 to 5 days, dentures are examined for any depressed surfaces which can be relieved. So it should be relieved after that duration. The material should be renewed once in 3 to 5 days till the tissue healing is complete. So yes, the patient has to come many times, and things have to be removed. It'll what do you call, scrape off easily. You can just take it out with your hand. Sometimes you'll have to use the burr if it set in a hard manner. So then impression with ZNO is taken over. The tissue conditioner material and cast is poured immediately. Okay. During the previous visit, an accurate orientation record of the maxillary denture should be recorded. Okay, so the orientation jaw relation is also important, which should have been established or you to establish again. Okay, so advantages are abused tissues can return to normal, a condition, a functional impression that incorporates the natural movements and relation of the jaw is developed by the patient. Okay, so coming to the lab procedures. So this is the second set of procedures. This has 2 to 3 methods. So coming to the articulator method, so impression is made in the denture to be relined. Okay, and then the impression material, denture impression is poured in the dental stone. So you can see, right, this has been poured. Okay, so now what happens is modeling clay is clay adapted denture. Blocking out of the denture is done. You can see it's done. It's fixed everywhere. Okay, except for the teeth. Stone is placed on the lower member and smoothened with spatula. Okay, so it's smoothened with spatula and the denture is settled in the stone mix. Okay, so that's how it looks when the jig or um, the member you can open when the articulator opens. Okay, so all impression materials must be removed from the denture. Okay, so a thin layer of resin must be removed from the inferior of the denture. So we're just removing any other material, any of the remaining acrylic material or resin material. Okay, so borders are reduced 2 to 3 mm. As you can see, any of the notches are obviously deepened. Okay. So the cast which we obtained, what you saw in the first photo, so any of the resins are grinded, removed with the steam of air. So anything is removed. The PPS is highlighted and depressed. It's drawn and from the carver or from an instrument, it is deepened in the cast. So for the proper visibility, so this paint foil substitute is so a separating media basically is painted over. So a autopolymerizing resin is placed on the denture. Okay, and of course, uh, all the air bubbles are avoided. Place resin on cast and the resins are placed on the cast and in the border reflections. Okay, denture is seated in indentation. So the denture is seated again in the same indentation as you remember in the first cast, and the articulator is closed. A relined denture cured in pressure container for 30 minutes. Excuse me, sorry. It has been cured now, and then you can see that this is the relined denture, okay, with the extra base. So you can see the extra base, the color, okay, is examined for voids and nodules, and it is finished and polished. Okay, so now coming to the lab procedures. Okay, coming to the lab procedures for rebasing. So, uh, first one is the jig method. So in the jig method, what happens is this is the jig which is there. Okay. So it's like the stone index is formed in the lower member. So you put the POP or impression plaster and you just embed the denture in it. So this is the lower member. Okay, this is our cast and the denture. So it is put in a duplicator or a jig. Okay, denture mounted on its cast to be relined. Okay, so this is the jig, and it's secured by the bolts so it doesn't move. Okay, so now what happens is, so in this case, porcelain denture teeth were used. So uh, that's why we are talking here about porcelain denture teeth. So same thing can be done by acrylic denture teeth. So in this case, um, the teeth are removed from the denture by heating alcohol torch or hot spatula. So it is actually removed. It can be removed. Okay, so porcelain teeth have been replaced in their indentation in the stone index. So you remember the stone index we took. So the teeth are put in the stone index. So there now comes the ridge area. So you adapt a layer of base plate wax, okay, and assemble it back to the jig. Okay, so wax up of the denture teeth to base plate wax, okay, is done. Then we remove the cast flask and process it with the heat cure denture based resin. Okay, so you can see everything has been done. Then the cured denture is placed on the jig to check the occlusion and finish and polish. So the new denture is placed, sorry, here. So the new denture again is placed and checked for any occlusal discrepancies and any um, overextensions, and it is removed and finished, polished. Okay, coming to the flask method in the laboratory method. So denture is half flasked. Okay, silicone mold material is painted on the denture and teeth. So this is one method. Okay, flask is opened. Okay, so you will see that the denture base is on the other side, and of course the impression is on the other member of the flask. So porcelain teeth looks like this, and resin teeth, like what we do, looks like this. Now cast and investing stone is painted. Okay, so it's just separating media basically is painted. Okay, so the denture is cured, ready for finishing and polishing. So finishing and polishing is done, right? Okay, so heat cured relines have the following deficiencies. The patient must be without his denture for a period of at least 1 day. Reheating the original denture base to cure the added acrylic resin releases residual internal stress called wrappage. So what does wrappage mean? It means is any bending or twisting out of the shape which results basically from heat or damp is known as wrappage. So that can also, you know, take place. Processing changes can take place. Okay, if you use an autopolymerizing material, then it can be mixed and poured. Do just follow the manufacturer's instruction. The duplicating instrument is closed completely so that the master cast will be correctly positioned back within the denture. After curing, the denture is removed from the master cast and finished. Okay, so chairside procedure, the last procedure in the lab, um, the last procedure. So we are finished with the lab procedures. So the method uses the acrylic that can be just added to the denture and allowed to set in the mouth. So it's like a instant relining, rebasing thing. So an example is rebase too. Okay. Okay, so disadvantages are that it is an unpleasant to the patient. The flow of the material is kind of sluggish, so it's really doesn't flow at a proper the way we want. There can be adequate occlusion, which is very difficult to maintain. If it is not positioned properly, then it can go wrong. Border thickness and length are difficult to control. Tissue surface defects are common. Porosities of the resin is a problem. The color of the material is not stable. So you understand in short. Chairside material does not, chairside procedure does not work, guys. Okay? All right. So the clinical method is the best method. Lab methods are also good. Okay? So coming to the last part of the presentation, which are a few more slides, guys. So it's coming to the repair of the complete denture. Okay, so first we can see what are the reasons of denture fractures. It can be during function or dropped on a hard surface, which we should not drop, right? So the key to repair is accurate reassembling and alignment of the broken parts in their original position. Okay, so classification of the fractured dentures. So it is according to the location, it is the midline, any part fractures. Okay, according to the extent of the fracture without broken or missing part, with broken and missing part, or teeth, according to timing of the fracture, early fracture, delayed fracture. So I'll tell you what that means according to the cause of the fracture, so by the operator or by the patient. Okay, so denture repair can be classified also in tooth replacement and fractured denture. So tooth replacement, anterior teeth, posterior teeth, these are more successful. Okay, coming to fractured teeth, separated parts, so it can have non-separated parts or it can have missing parts. Okay, most commonly seen are the midline fractures, mainly in the maxillary denture. Causes are insufficient relief in the midlines. Okay, this is known as the early fracture, and ridge resorption, which is a delayed fracture. This is a very common cause of fractures in the dentures, okay? Residual ridge resorption, okay? All right, so procedure to repair the midline fracture. Broken parts are assembled and fixed together by sticky wax. You can see that sticky wax. And then just to strengthen, you can put burrs or plastic sticks to stabilize, okay? Then what happens is we block all the undercuts by wax or clay. Okay, the fitting surface is painted with separating. So now the stone cast is poured into the fitting surface. Okay, we let it settle, and then the cast, the denture is clean, and any sticky wax is removed. Okay, fracture edges are reduced, widened, and beveled and polished, and dovetails are created, like you can see, to strengthen the joints. Okay, repair joints. Okay, and now cast is painted by separating media, and the denture is secured to the cast with the rubber band, and self-cure acrylic is placed and modified and filled, and then later you can, sorry, which can be repaired as mentioned. Fractured with missing or lost parts. So now we're going to concentrate on this. So what happens is an impression is made with the denture placed in patient's mouth. After pouring the cast, either a self-cure acrylic is placed, applied or placed to the missing part, or wax is added and carved to reassemble the broken denture part, okay, like that. Then the whole thing is flasked, packed, and cured, and finished and polished. Okay. So another method to do the same is a plaster index, that is known as the key. This is the key, okay, to make a record and secure the position of wax teeth. So teeth to be replaced, repaired, are removed together with all wax around them. Okay, so all the wax are removed. The teeth are then put back exactly on the original position, aided by a plaster key. A self-cure acrylic resin is added from the lingual side until repair area is overbuilt. Okay, so um, you just place the self-cure acrylic, and then you cover it up, and then after curing, the index is removed and the denture is finished and polished. So again, you can check if it is accurate or not. Okay, so it's like a putty index, yeah, like that. So this is a plaster index. Okay, you call it a. Okay, now coming to the posterior teeth replacement. Okay, so mounting of the denture done on an articulator. So we remove any fractured resin tooth by grinding it with a burr. So we take care to preserve the facial gingival margin of denture base and not to perforate any of the base. Okay, so and now we allow the tooth bearing surface to be modified, and we correctly place the tooth. Okay, now the articulator is closed. We check the occlusion, it's correctly sealed properly with wax. Okay, and again, now you can paint the polymerizing resin into the ridge lap area, which is this, and the tooth is nicely sealed together on the denture base. Okay, so place the, okay, so here all, okay, so now what you have to do is anyway, you just cure it up for 30 minutes and adjust the occlusion and polish and repair and denture and not the denture, the teeth, and see if there are any high points. You can just check and trim it off. Okay, so now the dentures are finished and polished, as you can see in the photos. Okay, so guys, that was the end of our presentation, and so coming to the conclusion, each of the method can produce satisfactory result. Success depends both on the clinical and lab skills of the operator, but reline or rebase are not an accurate, adequate substitute for new dentures. Okay, so we need to know when do we need to do these procedures and when do we actually need to make a completely new denture, and of course also about repairs, that we need to know when do we really need to repair the denture, or do we have to just discard and make a new one. Okay, so guys, you can read any of the complete dentures textbooks for this topic. There are many. There's Winkler, Boucher, many are there. Okay, so and if you have any further questions, guys, I am always in the prosto department in Polyclinic 3. Come and ask me for any doubts, guys. Thank you for patient listening.